This is a different type of video than the ones I usually make. There will still be evidence-based medicine, and the studies will be shown on the screen. However, this isn't just about migraine. This is about a war on women's hormones, and even more so, the ethical standards in medicine, or what seems like now the lack thereof, by certain players that hide behind the names of their organizations. Let's begin. 1 in 4 women on the maximum approved dose of hormone therapy aren't getting enough estrogen into their bloodstream. And that's not my opinion. That's peer-reviewed data, published in February 2025 in the journal Menopause. So what happens to those women? According to the British Menopause Society, they should just stay undertreated because prescribing higher doses is concerning. Meanwhile, the doctor who actually published the research, who runs the largest menopause clinic in the UK, who has helped tens of thousands of women, has been stripped of her BMS specialist status and removed from the organization entirely. Her name, Dr. Louise Newson. And what's happening to her isn't just about patient safety, it's a professional witch hunt dressed up as medical caution. Today, I'm going to show you the science. And I'm going to show you how badly the establishment has gotten this wrong. So first, let's start. Let's call this part 1, the safety alert. In April 2023, 6 major medical organizations issued a joint safety alert. The British Menopause Society, the Faculty of Sexual and Reproductive Healthcare, the Royal College of General Practitioners, the Royal College of Obstetricians and Gynecologists, Society for Endocrinology, and the Royal College of Nursing Women's Health Forum. Let me read to you what they said. The guidance is to aim for the lowest effective dose to control symptoms. We could agree on that. And estrogen should not be regularly prescribed in doses higher than the upper limit listed in the individual summary of product characteristics, as these limits are informed by the results of clinical trials to ensure patient safety. Except that's not true. The early dose finding studies that established those limits were designed to measure pharmacokinetics and efficacy. They were not designed to assess long-term safety, and the sample sizes were tiny. Let me say that again. The safety limits the BMS is using to attack Dr. Newson are based on studies of 11 to 50 women that weren't even designed to measure safety. The alert continues. Those finding studies assure that symptom control is achieved within robust safety parameters. This is demonstrably false. We now have data from 1,508 women showing that 1 in 4 on the maximum licensed dose don't achieve symptom control because their estradiol levels are subtherapeutic. The dose-finding studies got it wrong. They assumed a predictable dose-response relationship that doesn't exist in real-world clinical practice. That's the difference between efficacy and effectiveness. This is basic medical school pharmacology. Not a good look for the BMS. But here where it gets truly absurd. The BMS's own November 2024 statement says, some women may require higher doses of estrogen outside the licensing guidelines, but this should not be regarded as standard practice. So they acknowledge some women need higher doses. It's right there on their website. So when Dr. Newson identifies those women through clinical assessment and prescribes higher doses to achieve therapeutic effect, she gets stripped of her BMS specialist status. She gets removed as a BMS member. The BMS never audited her clinical practice. They have no data on her actual prescribing patterns. They have no documented evidence of patient harm, but they removed her anyway. Meanwhile, internal BMS emails obtained through data requests show officials describing her as the Joan of Arc of menopause, or the doctor who discovered menopause 2 years ago, an irritant and the threat and the menopause messiah. So this isn't scientific disagreement, is it? That's professional resentment. This is absolutely repugnant and childlike behavior by these so-called professionals. Now, let's discuss something they likely missed or willfully ignored. And let's call this part 2, the absorption problem. Let's talk about the science the BMS is ignoring. In February 2025, Dr. Newson's clinic published the largest real-world study ever conducted on transdermal estradiol absorption. The same study I referred to earlier of the 1,508 perimenopausal and postmenopausal women. So keep in mind, this was published in Menopause, one of the top journals in the field. The reference interval for serum estradiol was 54.62 to 2050.55 picomoles per liter. That's a nearly 40-fold range. Previous research has shown up to 10-fold differences between women using the exact same dose of the exact same product. Why? Because absorption depends on dozens of factors. It depends on age, skin thickness, blood flow, application site, whether you washed within an hour of applying gel, even the temperature of your skin. Here's the critical finding. Among women using the maximum licensed dose, a 100 microgram patch, or 4 pumps of gel daily, 24.84% had subtherapeutic levels, below 200 picomoles per liter, below the threshold needed to relieve symptoms or protect bones. 1 in 4 women on the highest approved dose still undertreated. For women on any licensed dose, the number was even worse. 31.73% had subtherapeutic levels. And here's what the BMS doesn't want to talk about. Off-label doses didn't increase the risk of having dangerously high levels. The study found no statistical association between using off-label doses and having elevated estradiol. Why? Well, because most women on higher doses are poor absorbers. They're not getting super physiological levels. They're finally getting normal levels for the first time. The study's conclusion: dose customization is key to ensure that all women can reap the benefits of hormone therapy. That's exactly what Dr. Newson does. That's exactly what she's being punished for. The BMS keeps talking about safety. We don't have data confirming these doses are safe. Well, let's unpack this. The maximum licensed doses aren't safety limits that are based on harm data. The early dose finding studies that established those limits were designed to measure pharmacokinetics and efficacy. They weren't designed to assess long-term safety. And again, the sample sizes were tiny. Second, if we're going to demand safety data, which is fair, let's be consistent. Where's the safety data showing these doses are harmful? It doesn't exist. The BMS is demanding proof of safety while ignoring the complete absence of evidence for harm. Third, the women using higher doses are often achieving the same blood levels as women who absorb well on standard doses. If a good absorber on 50 micrograms reaches 400 picomoles per liter, and the poor absorber on 150 micrograms also reaches 400 picomoles per liter, why would the poor absorber be at higher risk? She wouldn't be. That's the point. But let's go deeper, because the entire fear of hormone therapy traces back to one study, the Women's Health Initiative, published in 2002, and I'm going to refer to it as WHI from now on. The study was halted early because of increased breast cancer and cardiovascular events. It caused millions of women to abandon hormone replacement therapy overnight. Here's what the panic missed. The WHI tested conjugated equine estrogen derived from pregnant horse urine combined with medroxyprogesterone acetate, a synthetic progestin. These are fundamentally different from body-identical estradiol and micronized progesterone that Dr. Newson prescribes. Mean age of participants was also 63.2. Over 70% were aged 60 to 79. These women were on average 12 years past menopause. Even the WHI authors acknowledge that their results do not necessarily apply to lower dosages, other formulations, or estrogens and progestins administered through the transdermal route. 20 years of follow-up research has transformed our understanding. The 2020 JAMA 20-year follow-up found that estrogen alone actually reduced breast cancer incidence by 23% and breast cancer mortality by 40%. The ESTER study found that oral estrogen increased clotting risk 4.2-fold, while transdermal estrogen showed no increased risk whatsoever. The E31 French cohort study, which included 80,000 women, found that estrogen combined with micronized progesterone had no increased breast cancer risk. Synthetic progestins, however, increased risk by 69%. The formulation matters. The route matters. The type of progesterone matters. Dr. Newson prescribes transdermal body-identical estradiol with micronized progesterone. The evidence shows this combination has a fundamentally different and safer risk profile than what the WHI tested. Now, let's talk about the endometrial cancer red herring. The April 2023 safety alert made a big deal about endometrial protection. There's good clinical evidence in relation to the dose of progestogen required alongside licensed doses of estrogen to adequately protect the endometrium against hyperplasia with atypia, a risk factor for endometrial cancer. So they're implying that higher estrogen doses without proportionally higher progestogen creates cancer risk. Sounds scary. Except Dr. Newson's clinic has actually published data on this. In 2025, they reported on 235 women using body-identical hormone regimens. The result? 0 cases of endometrial hyperplasia. 0 cases of endometrial cancer. They're worried about a theoretical endometrial risk while dismissing the proven breast cancer difference between progesterone types. And here's what's bewildering me. The safety alert says women on higher estrogen doses need proportionally higher progestogen doses. But many women on higher estrogen doses are poor absorbers who are only achieving normal blood levels. They're not exposed to excess estrogen, excess progestogen. The BMS is treating dose as a proxy for exposure, but dose and exposure aren't the same thing when absorption varies tenfold between women. I mean, come on. Part 4, let's call this patches versus gels. Here's something else the BMS isn't discussing. The choice between patches and gels matters, especially for certain patients. The Glenn study found that gel users had significantly greater variance in blood levels than patch users. In a randomized crossover study comparing the two, peak levels varied 11-fold with gel versus 7-fold with patches. Why? Well, with patches, drug release is controlled by the patch matrix. It's consistent. With gels, absorption depends on application site, surface area, technique, skin type, and whether you washed or sweated after applying. Real-world variability is huge. Gel users achieve median levels, which is why some women do better on gels, but the variability can be a problem. This matters especially for migraine patients. Hormone fluctuations are a well-established migraine trigger. That's why menstrual migraine occurs when estrogen drops before menstruation. Stable hormone delivery reduces these fluctuation-triggered attacks. A 2024 review in Neurobiology of Pain found that testosterone has an anti-nociceptive effect and may protect against migraine. Postmenopausal women with migraine had lower testosterone levels than controls. Testosterone therapy improved migraine severity in these studies. Dr. Newson advocates for comprehensive hormone therapy, including testosterone when indicated. The emerging science supports her, but if a woman needs stable estrogen delivery and she's a poor absorber on standard patch doses, what should her doctor do? According to the BMS, apparently nothing, just leave her undertreated. According to Dr. Newson, you adjust the dose until her symptoms resolve and her levels are adequate. Let me be clear, I want to be direct and I don't want to mince words. One of those approaches is evidence-based medicine, Dr. Newson's. The other is bureaucratic cowardice. I hope that was clear. Let's talk about the harm the BMS isn't measuring, the harm of undertreatment. And let's call this part 5, the real harm. Remember, the 2023 safety alert was signed by 6 organizations. It told doctors to aim for the lowest effective dose and warned against prescribing above licensed limits. The Glenn study describes what happened next. Failing to emphasize that there is a paucity of safety data to inform dose recommendations, failing to acknowledge that the lowest effective dose might be an off-label dose for many women, and deliberately discouraging clinicians from prescribing off-label doses has resulted in considerable anxiety and confusion for general practitioners and women using hormone therapy in the UK. The result, many GPs, general practitioners, no longer prescribe off-label doses. Some have refused to prescribe hormone replacement therapy altogether, and many women are turning to private menopause specialists because they are unable to access the care they need in the NHS, the National Health Service. The safety alert created the problem, and now the BMS is punishing the doctor who's solving it. But the harm goes far beyond confused general practitioners. 2013 analysis in the American Journal of Public Health estimated that between 2002 and 2012, nearly 91,000 premature deaths occurred among U.S. women with hysterectomies aged 50 to 59 who avoided HRT following the WHI panic. 91,000 women dead because they were scared away from a treatment that would have helped them. Beyond mortality, untreated menopause causes accelerated bone loss of 3 to 5% annually for 5 to 7 years, leading to fractures. Cardiovascular changes that increase long-term heart disease risk, cognitive symptoms that women mistake for early dementia, quality of life impairment that destroys careers and relationships. And despite all this, research suggests 75% of affected women remain untreated. And now to part 6. The double standard. Let me point something out that should make everyone uncomfortable. The April 2023 safety alert demands we stay within established guidelines and robust safety parameters. But what are those parameters for other hormonal prescribing? Doctors prescribe synthetic hormones to teenage girls for contraception without controversy. Combined oral contraceptives contain roughly the equivalent of 200 to 300 micrograms of transdermal estradiol. Hormones are also given to transgender patients, often at doses that achieve supraphysiological levels for their natal sex. But when a menopausal woman wants adequate replacement of the hormones her body produced naturally for decades, she faces bureaucratic gatekeeping and fear-mongering. A 2025 study in cephalalgia examined 27,055 women with migraine using modern combined hormonal contraceptives. No significant increase in vascular events compared to non-users were found. The guidelines restricting estrogen in migraine patients were based on high-dose formulations from the 1960s. The evidence base is decades out of date. And yet, when Dr. Newson, who has passed her required annual appraisal, who has published peer-reviewed menopause research, when she prescribes individualized doses to women who need them, she gets removed from the very organization that wrote that safety alert. The safety alert claims to be about patient safety, but where's the safety data showing the harm from Dr. Newson's approach? It doesn't exist. Where's the audit of her clinical outcomes? Never happened. Where's the comparison of her patient outcomes to those of doctors following the guidelines? They haven't done one. 6 organizations signed that alert. Not one of them has published real-world data on 1,508 women showing actual estradiol levels and absorption variability. Dr. Newson's clinic has, and the data proves she's right. Now, here's what we know. We know that nearly 1 in 3 women on licensed HRT doses have subtherapeutic estradiol levels. We know that transdermal body-identical estradiol with micronized progesterone has a fundamentally different safety profile than the oral synthetic hormones tested in the WHI. We know that absorption varies up to 10-fold between women and that the dose must be individualized to achieve therapeutic effect. We know that international guidelines, not in the UK, including from the North American Menopause Society and the IMS, support individualized dosing without these arbitrary limits. Again, this is unique to this specific location, and that's important. We know that undertreating menopause has real costs to women in suffering, in bone fractures, in cardiovascular disease, in cognitive decline, in economic productivity, and in lives. And we know that Dr. Louise Newson has published the research proving all this, built a clinic that treats women according to the evidence, and been systematically targeted by an organization that claims to advocate for menopausal women. The BMS says they're concerned about prescribing without safety data, but they show no concern about the documented harms of undertreatment. They show no concern about the 91,000 women who died avoiding HRT. They show no concern about the women who suffered for years before finding a doctor willing to treat them properly. Their concern is selective, and their actions speak louder than their guidance. Dr. Newson isn't a reckless maverick. She's a clinician who reads the literature and concludes that the conservative establishment position leaves too many women suffering unnecessarily. The evidence is on her side. The question is, why isn't the BMS? Women deserve to know that individualized hormone therapy is supported by evidence, that poor absorption is common, and that they have the right to adequate treatment. And if you're a menopausal woman struggling to get adequate care, know that you're not imagining it. The system is failing you, but the science is clear. Don't let outdated fears keep you from the treatment you deserve. I'll see you in the next one.